renal cyst infections is actually frequent during polycystic kidney disease, but there is no clinical data available about the medical management, neither the type of antibiotics nor their duration. We want to determine the risk factors for medical management failure and for recurrent infections after treatment. I am Julien Dang, nephrologist in Necker Hospital in Paris, and I'm going to talk about our article in Mayo Clinic Proceedings entitled The Efficacy of Prolonged Antibiotic Therapy for Renal Cyst Infection During Polycystic Kidney Disease. We decided to design a retrospective and observational study in Necker Hospital in Paris in the nephrology and infectious disease department by including all the patients with polycystic kidney disease diagnosed with renal cyst infection over 18 years. In total, we included 139 episodes of renal cyst infections, and as you see, all the patients were initially treated with only empirical antibiotic therapy. And we defined the initial antibiotic therapy failure by the persistence of clinical and or biochemical signs of infection such as fever, sepsis, persisting high CRP level or positive microbiological cultures beyond 72 hours of adequate initial antibiotic therapy that would require the modification of the initial therapy or cyst drainage or nephrectomy. We observed over 16% of initial antibiotic failure in our cohort. For the other 84% of patients, they will be treated with a follow-up maintenance antibiotic therapy. After 1 year of follow-up, we observed 14% of recurrent infections, defined by the recurrence of clinical signs of cyst infections at least 14 days after the end of the maintenance antibiotic therapy. All cases with subsequent documentation of a new microorganism were defined as a new episode. Renal cyst infections were diagnosed based on previously published data from Saleh and al. Briefly, definite infections were based on microbial culture obtained by the renal cyst puncture. Otherwise, the other cyst infections were diagnosed based on evocative radiological features combined with clinical signs such as abdominal or lumbar pain, with the exclusion of other extrarenal cause of febrile abdominal pain, and with the exclusion of renal cyst hemorrhage, except for cases with documented microorganism in blood and or urine culture, suggestive of secondary infection of cyst. We next sought to determine the risk factors associated with an increased risk of initial antibiotic therapy failure and recurrent infections during the first year of follow-up. By a multivariate logistic regression analysis, we observed that the male sex, the peak C-reactive protein level over 250 mg per liter, and the presence of radiological signs of cyst wall thickening were all associated with a 7-fold increased risk of initial therapy failure. Without surprise, we observed that patients with renal allograft were more likely to develop recurrent infections during the follow-up. What is more surprising, and what is the main point of our study, is that we observed a positive correlation between the antibiotic duration and the prevention of recurrent infections. Indeed, we observed that patients treated with over 28 days of antibiotic during maintenance antibiotic therapy were nearly completely protected from recurrent cyst infection. We also wanted to see that if the lipid solubility of the maintenance antibiotic therapy was associated with different outcomes during the follow-up. We indeed observed that lipid-soluble antibiotics such as quinolone or cotrimoxazole during our study were protective from recurrent cyst infection. In conclusion, our study highlighted a surprisingly high rate of renal cyst infections treatment failure and recurrent infections during PKD. We did not observe any influence of the empirical antibiotic in the early outcomes for the patients. However, we observed that a prolonged maintenance antibiotic therapy over 28 days nearly completely prevented the risk of recurrent infections, especially with lipid-soluble antibiotics. Our study suggests that medical management of renal cyst infections should rely on prolonged antibiotic therapy, preferentially with quinolones or cotrimoxazole. In refractory cases, one should imperatively look for resistant pathogens by renal puncture if possible. Prospective trials are now needed to confirm this data and to look for the potential of other strategies such as double therapy or nephrectomy for difficult cases.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.